the last talk of the session, and the topic I have been given me is that looks like uveitis, but it is not. So Partho already explained to you very beautifully that uveitis can produce either retinitis, which is very typical, or choroiditis, which again is very typical. But if you are seeing some deposits in the subretinal space, which is neither retinitis nor choroiditis, it is unlikely to be uveitis. And I have been showing this patient for years now because this patient was treated for TB with steroids, anti-TB drugs. This is not uveitis, this is CSR with fibrin deposition. And if you give steroid, it worsens it a lot. And the fluorescein angiography is very helpful. The choroiditis lesions are hyper to hyper. CSR will be hyper with more expanding in the late phase. Another such example, the laser burns, and you can see the child was playing with the laser toy shining into his eye, and this was confused with uveitis. There is no way a choroiditis is going to present like a linear lesion like this. So it's not uveitis, even though this patient did have IgG4 disease, but this problem is not related to uveitis. Dystrophies, I think I have been emphasizing a lot in this meeting, is about dystrophies because many of the time, for example, this patient was diagnosed as retinal vasculitis, and that is how the patient came. He was receiving treatment for retinal vasculitis, and the diagnosis was retinal vasculitis with retinitis pigmentosa. Now, if you see here, there are some bony spicules, and there is periarteriolar sparing, which is more characteristic as you see on the fluorescein and FAF. So you can see this typical pattern. This is not the pattern of leakage of uveitis. This is something masquerading, and this patient actually had CRB1 mutation associated Leber's congenital amaurosis. So there is no need to get confused and starting steroids. Similarly, this patient. This is the patient which was diagnosed as serpiginous choroiditis, but serpiginous choroiditis does not present so symmetrical, so flat, no leading edge, no yellow edge. It's just a flat lesion which is bilaterally symmetrical, and that's how you see it. This is actually helicoid peripapillary chorioretinal degeneration and not serpiginous choroiditis. Drug toxicities, this is what I wanted to highlight. There are two kinds of things. One is the drugs induced uveitis. The second is the drugs cause toxicities which can be confused with uveitis. Now this is a 68-year-old lady. She was diagnosed as intermediate uveitis in Canada and was being managed with immunosuppression. Now when you look at it, there was nothing much happening in the eye except the presence of this symmetrical bilateral kind of a pocket of fluid. Now this is not what you expect in cystoid macular edema due to intermediate uveitis. This is unusual. So I would put my money either on dystrophy, and if the dystrophy has been ruled out, these days we ask more and more about the history of the drugs. So this patient did give, we did fluorescein, ICG was normal, and fluorescein showed, something was happening there. She was actually on sertraline therapy, and when we look the literature, sertraline is known to cause some kind of maculopathy. So for her, we did electrophysiology. It did show changes. We just stopped the drug, and this is post 2 months after stopping the drug, the edema or whatever it was responded. So this is published in AIOC. Another case, This patient is a young child who had X-linked chronic granulomatous disease. Now, this is the disease which is caused by CYBB gene mutation and produces recurrent abscesses in the liver. So that he required multiple admission, IV antibiotics, pigtail catheter drainage, and was on oral itraconazole 200 milligrams Septron for the past 6 years for his systemic disease. He also received clox and linezolid 7 months back. So he came to us as a case of fungal endogenous endophthalmitis, knowing his history of the disease and predisposition to fungal infections. So, what we did, we ran the OCT through this, and this did show there was a lesion in the in a retina, but what was interesting was these microcystic spaces in the internal limiting membrane. That's not a feature of endogenous endophthalmitis. The literature search indicated that linezolide drug, which he was on since the last 7 months, is known to produce these changes in the inner retina and internal limiting membrane microcyst. So we discussed it over. He was already on itraconazole, even if it was fungal. So we did nothing except stopped linezolid. And you can see the top is before stopping when he presented. The bottom is after stopping linezolid 2 months later. So every case, the last part is that many a times you see serous detachment and you think it is VKH, but every case of serous detachment is not VKH, or CSR for that matter. For example, this lady had a mass-like lesion and there was fluid. You do the fluorescein angiography and this is very atypical. It's a mass-like lesion. So whenever in doubt, do an ultrasound. Ultrasound in VKH is very different. It is just diffuse thickening of the choroid, which you can demonstrate both on B-scan as well as on OCT, EDI OCT or swept source OCT. But this lady had a kind of a mass-like lesion, a flat mass, which had broad-based and had a height. There was associated retinal detachment. So these are the cases where you suspect choroidal metastasis. So there is no point wasting time on looking at anything. Just get a good history. She did fortunately give some history which could be pointing towards this. We just got the PET scan and it was actually poorly differentiated carcinoma in the lung for a 40-year-old lady who had no history of smoking or whatsoever. But it is just based on your clinical examination in the eye. So the conclusion is, if it does not look like uveitis, it may not be uveitis. So don't force the patient into a diagnosis of uveitis by pushing steroids and buying time. It may be you are seeing something which you are not aware of, which is not so common, or which is just a different manifestation. So it may be a good idea to review the literature. For example, that linolide toxicity and all, I wasn't aware. So when you go to the literature, you will invariably find that you are not the first one seeing these atypical cases. Somebody has already reported it before you. So that's all. Everything is not uveitis, Peter. Thank you.
Terrific. So I guess, Vishali, it comes back, doesn't it, to the clinical assessment, history, examination, and then going back to the history.
Yes. Yeah. Any questions from the house? Any questions, Dipankar? Right. It mostly causes, yes.
Seeing the optic nerve also along in this
And
doing the what you call other electrophysiological
right.
RNFL or CT.
And also very important, many patients on immune therapy these days, checkpoint inhibitors, they develop VKH-like disease. So if your patient is on checkpoint inhibitor as a part of chemotherapy, that's not likely to be VKH. That is the disease induced by checkpoint inhibitors. We were not seeing so much of drug toxicities, honestly, but now we have started seeing quite a few of them. So it's important not to mistake them for uveitis.
Yeah. Okay. Well, it's just on 4 o'clock,
Yes,
Vishali?
it's just for, and on behalf of International Uveitis Study Group, thank you very much for attending